Kanski lecture series, and this is going to be the Acquired Macular Diseases part 8, and in this part we are going to discuss about the vitreomacular interface disorders, and we are going to discuss about the epiretinal membrane and the full thickness macular hole. So epiretinal membrane is basically the membrane which is overlying the retina, and so that is why it is known as epiretinal membrane. Introduction. An epiretinal membrane is a transparent avascular fibrocellular structure that develops on or above the surface of the retina. Proliferation of the cellular component and contraction of the membrane leads to visual symptoms primarily due to retinal wrinkling, obstruction, and localized elevation with or without pseudocyst formation and CMO. So basically, ERM is a membrane which is transparent, avascular, fibrocellular, and it is present on the surface of the retina, and proliferation of these cellular component and contraction of the membrane can causes the visual symptoms primarily because of there is a retinal wrinkling, obstruction, and localized elevation and the formation of the cystoid macular edema. So the causes of epiretinal membrane can be idiopathic and secondary. Idiopathic, no apparent cause, as relatively high common aging process. The prevalence of the early ERM cellophane is approximately 6.5%, and advanced ERM pre-retinal macular fibrosis 2.6%. So basically it is an age-related ERM formation, and the early ERM is also known as the cellophane maculopathy, and advanced ERM as a pre-retinal macular fibrosis. Residual vitreous tissue remains on the retinal surface following cortical separation in around 50% of the eyes with subsequent proliferation. The predominant cellular constituent is a glial cell, probably derived from the indigenous posterior hyaloid membrane cell population laminocyte. So basically, after there is a posterior vitreous detachment, there are some of the vitreous tissue that remains on the retinal surface, and these vitreous tissue proliferates, and the main constitute of this material is glial cells, which is derived from the posterior hyaloid membrane cell population laminocytes. ERM development can occur at any stage of posterior vitreous detachment. It is now believed that the process of PVD from initiation to completion often extend over the course of years. About 10% are bilateral, tend to be milder than the secondary ERM. So these are milder and usually bilateral. 10% of these are bilateral. Secondary causes occur following the retinal detachment surgery. Most frequent cause of a secondary ERM. So most of the time it occurs after the retinal detachment surgery. Retinal break can cause ERM formation, panretinal photocoagulation, retinal cryotherapy, retinal vascular disease, inflammation, and trauma. Binocularity is dependent on whether both eyes are affected by the causative factor. Cell type most varied, with predominant pigment cells thought to be derived from the RPE. So diagnosis. Symptoms include blurring and metamorphosia. Mild cases are often asymptomatic. So signs of visual acuity is highly variable depending on the severity. An irregular translucent sheen cellophane maculopathy is present in early ERM, often best detected using a green red light filter. So overlying ERM is usually in it is like an irregular translucent sheen, and it is mostly best detected using a red free filter or a green filter. As the membrane thickens and contracts, it becomes more obvious there because of the macular puckering, and typically cause a mild distortion of the blood vessel. So whenever there is a thickening and contraction of the ERM, it causes the macular pucker formation, and there is a mild distortion of the blood vessel. Advanced ERM may give severe distortion of the blood vessel, marked retinal thickening as wrinkling and stria, and may obscure the underlying structures. Associative findings may include macular pseudohole, CMO, retinal telangiectasias, and small hemorrhage. And there can be associated findings: macular pseudohole, CMO, retinal telangiectasia, and small hemorrhage. Amsler grid testing typically show distortion. OCT show a highly reflective surface layer associated with retinal thickening. Disruption of the inner segment outer segment junction may be associated with the worst visual outcome following surgery. So basically on OCT you can see that there is a highly reflective surface on reflective layer on the retina surface, and there can be a disruption of the inner segment outer segment junction, and it is usually associated with the poor visual prognosis. OCT is also useful to exclude significant macular traction. FA has been superseded by OCT for routine assessment of ERM, but highlights vascular tortuosity and demonstrate any leakage. It is sometimes indicated to investigate the cause of ERM, such as prior retinal vein occlusion. So now fluorescent angiography is not usually performed, as OCT is a mainstay of investigation, and but sometimes it is used to indicate the vascular tortuosity and demonstrate any leakage. So how do you treat the case of ERM? Observation: if the membrane is mild and non-progressive, spontaneous resolution of the visual symptoms sometimes occur, typically due to separation of the ERM from the retina, as previously incomplete PVD completes. So basically you can do observation if the membrane is mild and non-progressive, and if there is an incomplete PVD, so you can wait for the completion of PVD, so it may get the ERM may get separated from the retina. CMO or tractional detachment may frequently require fairly prompt surgery to minimize secondary degenerative changes. So surgical removal of the membrane by vitrectomy to facilitate peeling usually improves or eliminate distortion. The main benefit, with an improvement in visual acuity of at least 2 lines in around 75% or more. In about quarter, visual acuity is unchanged, and in 2% get worse. So most of the time surgical you can do ERM peeling via vitrectomy. And what can it do? It can improve the visual acuity of about 2 lines in 75% or more, and in quarter visual acuity is unchanged, and in 2% it may even get worse. The surgical complications are principally those occurring after vitrectomy. Removal of the internal limiting membrane in concert with ERM peeling may be beneficial but remain controversial. Visual improvement commonly does not occur for several months post-operatively. Recurrence is late. Then there is a full thickness. So you can see this figure. There is a macular epiretinal membrane. A is showing as a translucent membrane seen with the red free light. So this is a membrane, and you can see there is a puckering of the macula area. And B is showing color image of the patient in A. So this is a membrane. You can see this is a whitish sheen. You can see C is showing as an advanced membrane. D is showing macular pseudo hole. OCT. T is showing us a macular pseudo hole. E is showing OCT showing high reflectivity interior to retina, foveal thickening and vitreomacular traction. F is showing a thickness map of E. So next is a full thickness macular hole. So whenever there is a hole in the macular area, most of the time it is at the fovea. It is known as a full thickness macular hole. So full thickness macular hole is a relatively common cause of a central visual loss with a prevalence of approximately 3 in 1000. So it is a common cause of a central visual loss, and it occurs in 3 in 1000 individuals. The onset is most common in female aged 60 to 70 years. The risk of the fellow eye involvement at 5 years is around 10%. The role of vitreomacular traction in the etiology of macular hole has increasingly been defined over recent years. A new OCT based classification has been published by the International Vitreomacular Traction Study Group with an intention of replacing the older GAS clinical classification. Both systems are discussed below, and vitreomacular traction is considered at a greater length as a separate topic later in the chapter. A new OCT-based classification has been published by the International Vitreomacular Traction Study Group with the intention of replacing the older GAS clinical classification. So there is a new classification of the macular hole which is based on OCT, and that is replacing the old GAS classification, which is usually clinically assessment. Both systems are discussed below, and vitreomacular traction is considered at a greater length as a separate topic later in the chapter. Other causes of a full thickness macular hole include high myopia, which can lead to macular retinal detachment, blunt ocular trauma. So the causes of macular hole can be high myopia or blunt ocular trauma. The lesion that may sometimes have a similar appearance include macular pseudohole and lamellar hole. See vitreoretinal traction, see below. So clinical feature presentation of a symptoms presentation of a full thickness dehiscence may be with an impairment of a central vision in one eye, or as a relatively asymptomatic deterioration first noticed when the fellow eye is occluded or at a routine sight test. So most of the time there is a distortion or impairment in the central vision in the one eye, and it can also be be seen if the one eye is occluded. You can see that there is a deterioration on the other eye. Symptoms are absent or mild prior to the development of a full thickness lesion. Metamorphosia may be present, so there can be distortion of image as well. Signs and OCT features. So there are 4 stages of the macular hole, which is from the 0 to 4. 0, 1, 2, 3, 4. So stage 0 macular hole, IVTS, which is a vitreomacular adhesion, was term proposed originally to denote the OCT finding of an oblique foveal vitreoretinal traction before the appearance of a clinical change. So basically there is an traction on the fovea without any changes in the fovea, which is also known as a vitreomacular adhesion. So next is a stage 1A, and there are in the stage 1 there are 2 stages, stage 1A and stage 1B. Stage 1A is an impending macular hole, and stage 2A 1B is an occult macular hole. So stage 1A impending macular hole, IVTS vitreomacular traction, appear as a flattening of the foveal depression with an underlying yellow spot. Pathologically, the inner retinal layer detached from the underlying photoreceptor layer, often with the formation of a cyst-like sheaths cavity. The differential diagnosis of a foveal yellow spot include adult vitreoform macular dystrophy, solar and laser pointed retinopathy, and CMO. So in a case of a 1A impending macular hole, so there will be that fovea is a little bit of depressed, but in a impending hole the fovea become flattened, and there can be a separation of the inner retinal layer from the underlying photoreceptor, so it can cause a schisis like a cavity, and the differential diagnosis is basically adult vitreoform macular dystrophy, which is known as Best disease, solar and laser pointed retinopathy, and CM. Then stage 1B, which is known as occult macular hole, IVTS vitreomacular traction, is seen as a yellow ring. A high resolution OCT of a normal macula is shown in figure 14.46a. With the loss of a structural support, the photoreceptor layer commonly undergoes a centrifugal displacement. So in a stage 1B it is shown as a yellow ring. So stage 2 is known as a small full thickness macular hole. So the small hole is basically when the hole size is less than 400 micrometer diameter. Small or medium full thickness macular hole with the VMT consists of a full thickness hole less than 400 micrometer in diameter at its narrowest point. The defect may be central, slightly eccentric, or crescent shape. So it can be central defect, it can be eccentric, or it can be crescent shape. A dehiscence is present in the inner retina with persistent vitreofoveal foveolar adhesion. Stage 3 consists of a full-size macular hole, IVTS, medium or large full-thickness macular hole with VMT. A full-thickness hole greater than 400 micrometer in diameter with a red base in which yellow-white dots may be seen. A surrounding grey cuff of a subretinal fluid is present, usually present, and an overlying retinal operculum, sometimes called a pseudo-operculum, may be visible. So basically stage 3 is a greater than 400 micrometer but without PVD. But if there is a PVD, it is known as a stage 4 macular hole. Visual acuity is commonly reduced 6/60 but is occasionally better, particularly with eccentric fixation. An operculum consisting of primarily of the glial tissue and condensed vitreous cortex, though 40% contain photoreceptor element. By definition, there is a persistent parafoveal attachment of the vitreous cortex. Stage 4 is a full-size macular hole with complete PVD, IVTS, small, medium, or large full-thickness macular hole without VMT. The clinical appearance is indistinguishable from stage 3. The posterior vitreous is completely detached. So, basically, stage 4 consists of a full-thickness macular hole with a complete PVD. The posterior vitreous is completely detached, often suggested but not confirmed by the presence of a V ring. A significant proportion of the idiopathic macular hole have been associated ERM. So then there is a spontaneously resolved macular hole. So usually, if if the stage is of full thickness macular hole is less than stage 2, most of the time it can resolve on its own. Macular hole may heal spontaneously, often resuming a near normal or even normal clinical and OCT appearance. A tiny outer retinal, often inner segment, outer segment junction, or other subfoveal defect may persist after spontaneous or surgical closure. Solar retinopathy commonly give an appearance similar appearance as the scarring from several other conditions where foveal center is a focus of damage. So whenever if there is an inner segment outer segment disruption, it can have a poor visual prognosis. Then there is a macular microhole, which is referred to a hole that is less than 150 micrometer in diameter. A macular microhole refers to a small, less than 150 micrometer full thickness foveal retinal defect that in a current classification of a vitreoretinal interface pathology is synonymous with the small thickness, full thickness macular hole stage 2 above. Symptoms are often minimal and may consist of a mild central blurring, metamorphosia, or disturbed reading vision. So most of the time it is included in stage 2 because it is less than 400 micrometer in diameter. Visual acuity is typically impaired less than with a larger full thickness macular hole, and abnormality may be noticed immediately. The full thickness defect typically heals within a few weeks, and by the time of initial examination, only a well demarcated red spot rather than a visible full thickness defect may be present. At this stage, OCT may show only a small defect in the inner segment outer segment layer. So let's see figure 14.45. A macular hole is showing us an occult 1B. B is showing us a small full thickness stage 2 macular hole, and C is showing full size stage 3 macular hole because it is without PVD, and D is showing us an OCT of the stage 3. So you can see the full thickness macular hole up to the RPE. So investigation consists of ancillar grid. So next is basically the OCT classification 14.46. It is in a high resolution OCT. A is showing us a normal OCT. B is showing us a 1B OCT in which there is a vitreomacular traction, and there is showing attachment of the posterior hilar to fovea, separation of a small portion of the sensory retina from the RPE in the foveolar region. So you can see that there is a separation and intraretinal cystic changes. C is showing us an eccentric stage 2 small full thickness macular hole with vitreomacular traction, showing attachment of the vitreous to the lid of the hole and the cystic changes. D is showing stage 3 medium or large full thickness macular hole with VMT with intraretinal cyst. So this is showing us a stage 3. E is showing us a stage 4 after the large full thickness macular hole with more VMT, showing a full thickness with the intraretinal cystic spaces and closure and an overlying operculum. So you can see that there is an operculum here, sometimes referred to as a pseudo operculum. And F is showing stage 4 after the surgical closure, showing an outer retinal disruption, a disturbance. So you can see that there is a disruption in the outer layers. So this is showing us a resolved macular hole, showing a tiny focal inner segment outer segment junction deficit on the OCT analysis. So next is the basically investigation. So ancillar grid testing will usually show non-specific central distortion rather than scotoma. So then there is a Watsky-Allen test. So Watsky-Allen test is basically a slit lamp examination with the fundus lens in front of the eye. So if the patient complains that the slit is being broken, it means that this is a positive Watsky-Allen test. Watsky-Allen test is performed by projecting a narrow slit beam over the center of the hole vertically and horizontally, preferably using a fundus contact lens. A patient with a macular hole will report that a beam is thinned or broken. Patient with other pathology usually see a distorted beam of a uniform thickness. OCT is extremely useful in the diagnosis and staging. FAF shows a markedly hyperfluorescent foveolar spot in stages 3 and 4 and punctate fluorescence in stage 2. FA in a full thickness hole show a very well defined window defect due to xanthophyll displacement and RPE atrophy. So in the case of FA, it will be window defect and the area will become hyperfluorescent. In the light of effectiveness of OCT in this condition, there is no need to undertake fluorescent angiography in routine cases. OCT is key to the confirmation of the diagnosis of macular hole and staging purposes. So next is, what are the treatment? So observation can be done about 50% of the stage 1 hole resolve following spontaneously vitreofoveal separation so these are managed conservatively. So stage 1 is being managed conservatively. About 10% of the full thickness holes also close spontaneously, sometimes with the marked visual improvement. Spontaneous resolution is more common with the small full thickness macular hole. Treatment is not needed for spontaneously healed hole, though vitrectomy with ERM peeling is sometimes indicated. So there is another thing which is known as a pharmacological vitreolysis with ocrioplasm may be suitable for a small early stage hole. So there is a drug called replasmin, and it can be used to for the because it is a vitreolysis. It lies the vitreous, so it is also used in a small early stage holes. It is discussed in vitreomacular traction below. Surgery may be considered in stage 2 or greater holes, and for the small some lamellar hole, superior results are usually achieved in a smaller lesion present for under 6 months. So most of the time, if the surgery is conducted under 6 months of age, it have a good result, but substantial visual improvement has been reported in long standard cases. Operative treatment consists of vitrectomy together with the peeling of ILM facilitated by vital dye staining, relief of vitreomacular traction by either induction of a total PVD if not already present, or removal of the perifoveal vitreous, and gas tamponade. So usually the procedure of choice is ILM peeling, vitrectomy, ILM peeling, and then we do the gas tamponade. So peeling of the ILM which is facilitated by dye staining, then there is a relief of the vitreomacular traction by either induction of total PVD if not already present, or removal of the perifoveal vitreous. C is showing us then we do the gas tamponade. Extending period of the post-operative face down positioning is not needed with modern technique. The hole is closed in up to 100% of the cases, and visual improvement occur over the course of month in 80 to 90% of the eyes, with a final visual acuity of 6/12 or better in approximately 65%. So most of the time, 100% of the cases, the macular hole can be closed up, and with the final visual acuity of 6/12 or better in approximately 65% of the cases. Worsening of the visual acuity occur in up to 10% of the eyes. Mild residual abnormality on OCT, such as defect in the inner segment, outer segment junction, or other disturbance adjacent to the RPE, is common and may also provide a diagnostic indicator of a spontaneously healed macular hole or microhole. Complications are the same as those occurring after the vitrectomy. So next is a vitreomacular traction. So VMT is basically the same as the hole. Basically it is putting the the cortical vitreous is attached to the retina. So whenever there is a traction because of the separation of the posterior hyaloid membrane from the retina, it causes some traction, and due to this traction it causes changes in the retina, which is known as a vitreomacular traction syndrome. So introduction physiological PVD usually proceed gradually over an extended period to encompass complete separation from the macula and optic nerve head, complete PVD. So because the posterior vitreous is getting separated from the retina due to age related So it can, the traction can occur during this phase. If the adhesion of the gel persists at the central macula, an anomalous PVD is present and can precede a range of a macular condition. So whenever the PVD is incomplete and there is a traction on the macula, it can cause the changes in the macula. An expert panel of the International Vitreomacular Traction Study Group recently published a classification of a vitreomacular interface disease based on principally on OCT appearance in order to unify previously disparate terminology. So first there is a vitreomacular adhesion, there is a vitreomacular traction, and then there is a full thickness lamellar hole. A full thickness hole, this is the lamellar macular hole, macular pseudo hole, epiretinal membrane. So vitreomacular adhesion is just the connection between the vitreous and the macula. So vitreomacular adhesion refers to the residual attachment of the vitreous within a 3 mm radius of a central macula in the presence of a perifoveal vitreous separation. So this is like a macula is being attached. There is an attachment of the vitreous and there is a separation of the perifoveal vitreous, whereas the macula is being attached at the 3 mm of the fovea, whereas the periphery is being detached. In most cases, it constitutes a stage in a dynamic process of PVD, so may not incur pathological sequelae. There is no distortion of the foveal contour or any secondary retinal changes. Focal VMA involves an area of attachment of less than 1500 micrometer diameter. Broad VMA is greater than 1500 micrometer. So if there is a focal VMA, usually the area of attachment is less than 1500 micrometer. If a broad VMA is present, the attachment is greater than 1500 micrometer. Then there is a vitreomacular traction. Vitreomacular traction is defined as the presence of a retinal changes on OCT with evident perifoveal within 3 mm PVD. Distortion of the foveal surface contour and other structural retinal changes may be present. So basically, whenever there is a within a 3 mm area of the fovea, there is a traction on the macula, it can cause the foveal contour is lost and there is a retinal changes. It is known as a vitreomacular traction. Focal and broad types are defined as for VMA. Concurrent VMT is associated with other macular diseases, for example AMD, RVO, diabetic retinopathy. Oscillated VMT is not associated with other macular diseases. So this is a macular hole. A is showing us a 3-dimensional OCT of the stage 4 and B is showing FA, early hyperfluorescence secondary to window defect. This is known as a vitreomacular traction. A is showing us an OCT, so you can see that there is a traction on the retina and there is a changes in the fovea, there is a loss of foveal contour and there is a retinal thickening changes. And this is showing us after the PVD and there is an operculum and there is a full thickness macular hole. So next is basically the full thickness macular hole, a foveal lesion featuring interruption of all the layers of the retina from the internal limiting membrane up to the RPE. Full thickness macular hole can be small, less than 250 micrometer, medium 250 to 400 micrometer, or large greater than 400 micrometer. Other consideration include the status of vitreous with and without VMT and the presence of an identifiable cause such as trauma. So usually the hole can be divided into small, medium and large depending on the diameter. If it is less than 250 micrometer, it is known as small. If 250 to 400, it is medium, and if it is greater than 400, it is known as a large macular hole. Then there is a lamellar macular hole. So usually the full thickness macular holes involves all the layer of retina up to the RPE, but in the lamellar hole, the inner retinal layers are having a hole, whereas the outer retinal layers are still being not separated. So there is a partial thickness defect of the inner retina at the fovea, but maintenance of an intact photoreceptor layer. Its pathogenesis is incompletely defined but may develop from an anomalous PVD, sometimes following a foveal pseudocyst, or represent an abortive full thickness macular hole formation in some patients. Classically, lamellar hole was described as a sequelae to CMO, so usually it can occur after the CMO. So then there is a macular pseudohole. This lesion mimics the clinical appearance of the full thickness macular hole, but it is caused by the distortion of the perifoveal retina into the heaped edges by the ERM without any loss of a retinal tissue and near normal foveal thickness. There is a central defect in the membrane. VMT may be present. So sometimes the macula give an appearance of a hole, whereas the fovea is normal and there is no retinal tissue loss because of the heaped edges. So there are ERM formation and there is a heaped edges around the fovea, which is giving the appearance of the pseudo hole. Epiretinal membrane is independent of IVTS classification, but most eyes with broad vitreomacular traction have an associated ERM, so it can occur after PVD. ERM can also occur after PVD. Vitreous remnants on the retinal surface following PVD provide a mechanism for the development of an idiopathic ERM. So next is, how do you diagnose the case of the vitreomacular traction? So symptoms in VMT include a decreased vision, metamorphosia, photopsia and micropsia. So all the symptoms related to the fovea. It can occur decreased vision, metamorphosia, photopsia and micropsia, but are usually milder in the lamellar hole and pseudo hole and absent in VMM. Signs in VMT may include retinal surface thickening, wrinkling and distortion, foveal pseudocyst, CMO, macular sheaths or detachment and capillary leakage. So there can be signs that there can be retinal surface can be thickened, there can be wrinkling, there can be distortion, there can be CMO formation, there can be sheaths in the macula and capillary leakage. The limit of the attached gel may be visible as a whitish band or reflex. Visible changes may be subtle. Both lamellar holes and pseudo holes can appear as a discrete reddish oval or round foveal spot. OCT is the key investigation. So how do you treat the case of a vitreomacular traction? Treatment of the full thickness macular hole and ERM is considered under separate topics above, so we have discussed these. So observation is spontaneous separation occur in a proper proportion of a patient with VMT and is more likely in milder cases. Observation is appropriate in patient with VMA and in many cases of VMT. So then is a pharmacological vitreolysis. Intravitreal injection of the oxyplasmin, a recombinant form of a human plasmin, releases VMT in over 25% of the eyes and may close macular hole where VMT is present. 40% versus 10% with placebo. So basically it lyses ocrioplasm, lyses the vitreous and can cause the separation of the vitreous from the retina, and it can also allow the macular hole to heal. Results are generally inferior to vitrectomy. Smaller areas of a vitreomacular traction and small macular holes have better outcome. The presence of ERM is a poor prognostic indicator for ocrioplasm treatment. Diffuse retinal dysfunction of uncertain mechanism, including substantially decreased acuity, has been reported as a rare side effect. Pars plana vitrectomy with peeling of the adherent area and any associated ERM usually give good results in VMT. The benefit of vitrectomy for lamellar and pseudo hole is less clear cut, but is probably greater if a significant ERM is present. So you can also do PPV, especially if there is an adjacent associated ERM is also present. So that's it for the part 8. See you in the next lecture.